Now I'll be discussing the test based on the lung cancers. You are getting a patient with a hemoptysis, and which of the following the most significant risk factor? So, point to be noted that he has hemoptysis. Nothing else is given, but hemoptysis can occur in many conditions. Some of the important conditions where we can have hemoptysis: tuberculosis, lung cancer. This everybody knows, but before this should come is chronic bronchitis. This is not known to most of the students. Even in acute bronchitis also sometimes streak of blood can come. This can come in chronic bronchitis also. In other important condition is Wegener's. Hemoptysis can be there, and of course this can occur in case of mitral stenosis. Point to be noted, this is a cardiac condition, rheumatic heart disease, mitral stenosis, that can also cause hemoptysis. This is not known to some of the students. So, but what I want to convey, hemoptysis is a non-specific symptom, can occur in many conditions. But what to do? Well, don't forget lung cancer is one of the important conditions where we can have hemoptysis. Now, how to proceed? So, you are taking history. What is the point that will really tell you that this is maybe a case of lung cancer? Answer is 30 pack years of smoking. Okay. Point to be noted, he say most significant. This word is the beautiful word. The question is very simple, but examiner is very clever. He said most, again the same thing what he says, which of the following the most appropriate answer. Why I'm laying stress on this. So before that, let's talk about, but let's know what are the causes, what are the predisposing for the lung cancer. Smoking is the single most important. Single most is smoking, and increased risk of lung cancer by factor of 10. It has a special meaning. That means if there are two people, one is both are non-smoker at the moment. One two friends, good friend, one starts smoking and other doesn't smoke. The chances of lung cancer in the smoker in due course of time is 10 times as compared to normal, 10 times. Other factor is asbestosis. One thing more, if both asbestosis and smoking, that means the one person who is working in asbestos factory and he is smoking also, then the factor becomes 5. That means the person working in the factory of asbestosis, the 5 times chances of having lung cancer as compared to one person who is not, he is just working, not working in the factory and he is outside. But a person working in the asbestos factory and smoking, then his chances are 50 times as compared to a normal person. It means what? Those people who are working in asbestos factory, of course, they have to take full precaution for prevention, but there should be no smoking at all. Then arsenic, radon, nickel, chromate, aromatic hydrocarbon, and cryptogenic fibrosing. This is the very important. This is very important. Okay. Well, let's go back. Let's go back. Oh, it is also there. It is also there. Also there. Oh, it is also there. Right? So this is not a this cannabis is not a feature. Cocaine is again not a predisposing, but we have 3 things: this, and this. it can lead to cancer. It can asbestosis 5 times, and this is 10 times. 10 times. So now you understood the classical. There are 3 conditions which can predispose, but who is the topper? So topper is smoking. So now you also understood the one point which I always say, examiner always say, choose the most appropriate answer, which he said most significant. So no doubt smoking is the most significant. Factor that does not lead to is coal dust is a very frequently asked question. It's not a feature which predisposes, so it's not. Question number 2, we are getting a lifelong smoker, working asbestos, smoking asbestos both, chances are 50. This you know the answer, 10 multiplied by 5. What I want, smoking and asbestos are synergistic. Note down the word synergistic. Or I can say in a lighter way, if the person is smoking and working in a asbestos factory, he's adding fuel to the fire. Fuel to fire. Now you will never forget the synergistic effect of smoking and the asbestosis. We are getting a 58-year-old man. He's a chronic cough and found to have lung cancer. Oh, found to have lung cancer. And which of the following is likely to developing lung cancer? Now the question is changed. Which are likely to? It's not so. If you look into this, passive smoking is the answer. These none of them causes lung cancer. Coal dust, we just learned, they don't cause. These lead to asthma or COPD. They don't lead to lung disease. The passive smoking is the one after all the option. Let's learn about passive smoking. Okay. Well, there are certain chemical like radon, arsenic we mentioned in the predisposing condition for lung cancer. But in this list, none of the feature is there, which I discussed in the previous question. Okay. But the thing is, this patient got lung cancer because of passive lung smoking. Point to be noted, 15% of the lung cancer patients who never smoked, they do develop lung cancer. Passive smoking. Now, what do you mean by passive smoking? We go to, one person go to meet some other person. Okay, and the person is sitting in his chamber, in his office, and he is a heavy smoker. This gentleman who is sitting here is a heavy smoker. Now visitor come. Visitor is sitting and talking to this gentleman in his office in the closed chamber. He is a non-smoker, but he is, remember that the smoke is there in the whole room. So now this gentleman is smoking. He is inhaling the smoke. So this gentleman is known as passive smoker. So even the person is not smoking, the other person is smoking, but this gentleman is getting punishment. So remember, passive smoking, it's also predisposed to smoking, right? So next question, risk factor for lung cancer except the now coal dust. We all know arsenic, asbestos, they are all predisposing for the risk factor. So you are very clear about the questions on the risk factors. Now we go to the next topic. We are getting 69-year-old gentleman. Okay, 69-year-old gentleman, and he come with a cough for the last 4 weeks. Okay, and despite antibiotic etc., he has not improved. He never smoked. He never smoked. And examination is normal. He was an accountant. That means he never worked in a factory like asbestos. Chest X-ray shows opacification in the upper zone. CT scan revealed mass in the right upper lobe, suspicious of lung cancer. No other abnormality reported. And finally, we make a tissue diagnosis and that confirm that it is a case of cancer. What type of cancer? It is adenocarcinoma. What is the strongest reason we are thinking about? Is a non-smoker. He non-smoker. So the question is asked other way around. Which type of cancer can occur in non-smoker? Adenocarcinoma of the lung is occur in non-smoker. Rest all are strongly associated with smoking. And adenocarcinoma is also more common in female as compared to males. Okay, so one reason why the answer is adenocarcinoma is non-smoking. So let's talk in more detail by each one of the options. Adenocarcinoma is not necessarily associated with smoking. Again, a very interesting line. It never means that adenocarcinoma will never happen in smoker. It can occur in smoker also, but it's the one which occur more commonly in the non-smokers. Okay, and one more thing, it may come as a primary lung cancer. That means it's developing in the lung itself, but sometimes it can come as a secondary of adenocarcinoma from somewhere else. The primary is somewhere else. It is coming as a secondary to lungs. So friends, the key word to remember here are not necessarily associated with smoking, and it can become as a secondary also. So there are two keywords to remember in this particular slide. Now let's talk about other options. Squamous cell lung cancer, strongly associated with smoking. So definitely our patient is a non-smoker, so this possibility is ruled out. And this can even as a cavitate also. So there can be cavity formation in the chest X-ray, but in our case, check out that there was no cavity in our patient. The question, there is no cavity formation, and it is associated with the hypercalcemia. One more thing, golden line to remember: lung cancer with hypercalcemia, it is squamous cell lung cancer. Golden line to remember: you are getting a lung cancer and hypercalcemia, and it is a universal question asked in all the exams throughout the world, in step 1, step 2, everywhere. So the golden line to remember: if you are like this, you are dealing with a case of lung cancer, squamous cell lung cancer. Alveolar cell carcinoma, it's a rare and usually present as a productive cough with copious sputum, and classically on chest X-ray you get fluffy infiltrate on. Fluffy infiltrate is there, not the way in our question what they say. There is well defined opacity there, and there is no other lesion seen in chest X-ray, so that again is ruled out. Mesothelioma is occurred in those exclusively to asbestosis. Now come the catch point. What will say in a case of mesothelioma? Okay, which of the following is the most important predisposing factor? Or other way around, a person is working in the factory of asbestosis. Okay, So he is likely to develop lung cancer or mesothelioma. Even in a asbestosis, lung cancer is more common as compared to mesothelioma. Point to be noted very carefully. But one thing is there, mesothelioma occurs only on exposure to asbestosis. The golden line is mesothelioma is equal to asbestosis. Asbestosis. Mesothelioma means asbestosis. But other way around is not clear. Asbestosis doesn't mean always mesothelioma. No, it never means. It means it may be lung cancer or it may be mesothelioma also. Got it? This is a catch. Beautiful question. Squamous cell carcinoma is the favorite topic of all the examiner. So let us talk about it. Occurs in around 20% of the lung cancer. That means about 1/5. It has got a very large share. And they are most aggressive features. Now, what is the meaning of most aggressive? That's why majority of time, by the time you diagnose, it already has metastasized. It has gone to far off places. So, with the result, this patient need a different type of treatment. What is that? I'm going to discuss in a minute only, but as of now, just remember, majority of the cases, it is widespread metastasis there. Well, in our case, CT scan in the question, what we got it, CT scan showed, they never showed any metastasis. Metastasis not there, so perhaps a localized lesion, patient is a non-smoker, the squamous cell is out. And they are associated with hyponatremia. Friends, lung cancer with hyponatremia, you are dealing with small cell carcinoma of the lung. Golden line to remember. Lung cancer with hypercalcemia is squamous cell. Lung cancer with hyponatremia is small cell lung cancer. So we are clear about it. Why the answer to this question is adenocarcinoma. Which the following is least associated with small cell lung cancer? Answer is PTH. Why? Because this is the one which is associated with squamous cell lung cancer. Rest all hyponatremia, Lambert-Eaton syndrome, all are associated with small cell, but this is the one entity which lead to hypercalcemia. And I already told you that hypercalcemia means, golden line is hypercalcemia lung cancer is squamous cell lung cancer. So now the point is why this hypercalcemia occur. Again the point I mentioned that it is in this squamous cell lung cancer they secrete PTH related polypeptide. This PTH RP has a function similar to PTH, so they can induce hypercalcemia. But point to be noted, PTH level as such is reduced in lung cancer. So hypercalcemia occurs due to PTH like polypeptide. So let us see what are the paraneoplastic features that we see in the lung cancer. In small cell lung cancer, we get ADH, SIADH. There is increased level of ADH that lead to syndrome of inappropriate secretion of ADH. It's this entity which goes to hyponatremia. What I said, lung cancer with hyponatremia is small cell. ACTH, this is something I need to discuss in more detail. ACTH means it's a type of, it can lead to ectopic secretion of ACTH. So definitely it is going to produce picture of Cushing syndrome. Yes, So what you expect in a Cushing syndrome patient, obese patient, moon shape, hirsutism, etc.? Yes, we expect the patient to have a buffalo hump, okay, etc., buffalo hump, moon shape face, etc. But one thing, these are not the features. And in a typical case of Cushing syndrome, obesity is a feature. But here, these are not the feature, rather weight loss is a feature. Weakness is a feature. Why? It's not, remember, he's a case of lung cancer. He's not a case of Cushing syndrome only. So due to lung cancer, patient has weight loss, no obesity, no moon shape. But, but what can happen? Yes, it is true that that appearance of Cushing syndrome is not there, but metabolic feature like hypertension will be there. Hyperglycemia can be there. Hypokalemia is marked, is because the ACTH level may be very, very high. So there can be too marked hypokalemia. There can be metabolic alkalosis and muscle weakness. So they are more common manifestation in case of small cell. Lambert-Eaton syndrome, this is seen only in small cell lung cancer. Again, a golden line to remember. Lambert-Eaton syndrome is equal to small cell lung cancer. Golden line to remember. So friends, beautiful golden lines by which you can get the answer very quickly. Finally, squamous cell, I told you it secretes a PTH like polypeptide that lead to hypercalcemia. Now one more thing which is not known to 99%. In small cell, sometimes they can secrete calcitonin. And due to calcitonin in small cell, they can have hypocalcemia. This point is not known to 99%. So write it down. Hypocalcemia in a lung cancer is small cell lung cancer. And this is due to increased secretion of calcitonin. So hypercalcemia is squamous cell clubbing can be there. Then there can be hypertrophic pulmonary osteoarthropathy can be a feature. And hyperthyroidism can be there little bit due to ectopic secretion of TSH. Again, one point not known to most of the students, but this is not a very common feature. Not a very common feature. So friends, so in case of squamous cell, there can be PTH-related polypeptide and there can be ectopic TSH. So there are two paraneoplastic syndrome that we get in case. Important hormones which can lead to hormonal disturbance. Adenocarcinoma can have gynecomastia and HPOA. Hypertrophic pulmonary osteoarthropathy is seen in adenocarcinoma and gynecomastia in adenocarcinoma. Question 7. Least common in squamous cell. Answer is Lambert-Eaton syndrome. Now your concepts are clear. So the golden line was Lambert-Eaton syndrome is squamous small cell lung cancer. Hyperthyroid, I just mentioned to you because of increased TSH. Squamous cell, this is seen in squamous cell, hypercalcemia clubbing. They are seen in squamous cell. Lambert-Eaton is seen only in small cell. Question 8. We are getting a 69-year-old woman, muscle weakness, blurred vision, and about 18 units of alcohol a week, smoked 20 cigarettes for 30 years, very heavy smoker. BP is high, reduced breath sound. The blood picture is, what we are getting is severe hypokalemia, 24-hour urinary cortisol is increased, and glucose level is high, it is 18.2. Sodium is 149. Okay. So which of the following is the most likely cause? Patient is getting what? If you look into this, you are getting 24-hour free urinary cortisol is increased and severe hypocalcemia is there. They are all pointing toward the Cushionoid features. Cushing. And Cushing occurs due to increased ACTH. And the golden line is the only condition. So lung cancer with Cushing is small cell lung cancer. So lung cancer with Cushing features is small cell, simple small cell, right? In all other condition, we don't have ACTH secretion, especially. Now, can it be Cushing disease as such? Okay. Can it be Cushing disease as such? Let us see. Is a possibility is there. She is a persistent cough, which is creating blood also. So now he gave a clue, beautiful question, that hemoptysis is there. Hemoptysis occurs. We just read the causes of hemoptysis. Again revising, important causes are TB, lung cancer, and mitral stenosis, bronchitis, etc. Well, in this patient, Cushing disease, Cushing-like features are there, but Cushing disease will never give rise to. Cushing disease means pituitary adenoma. Pituitary adenoma. That will not give rise to hemoptysis. Adrenal adenoma will not give rise to hemoptysis. Adenocarcinoma of the lung will not give rise to Cushing-like feature. So, squamous cell lung cancer will not give rise to Cushing-like feature. That means increased 24-hour urinary cortisol indicate Cushing syndrome. So, the condition like Cushing disease and adrenal adenoma, they will lead to Cushing-like feature, but they will not give rise to hemoptysis. And the lung cancer will give rise to hemoptysis, but they will not give rise to Cushing-like features. Okay. Okay, so we are discussing small cell lung cancer with ACTH can cause Cushing syndrome. And other point I mentioned to you that in these patients, Cushing-like features are there, but they don't have typical Cushionoid features. Right, sir. This we have discussed in detail. Question number 9. 60-year-old woman patient, cough, hemoptysis, weight loss, abnormal chest X-ray, squamous cell lung cancer is there, and the lab parameters are calcium level is high, phosphate level is reduced, TSH is on the borderline, thyroxine level is normal. So PTH level is reduced and no bone pains. Cause of hypercalcemia? Now things are clear, it is PTH like polypeptide. Okay. Well, so let's discuss. PTH like polypeptide is the cause of hypercalcemia in squamous cell. This you know now, no need to write. Let's read more important. It is a PTH squamous cell leads to PTH like polypeptide, and again repeating, its action are same as PTH and it causes hypercalcium reabsorption. Okay. It keep on absorbing calcium. It is not under negative feedback. Point to it, normally PTH also causes resorption of calcium from the bone, but it is under negative feedback. After a certain level, when the calcium level is normal, it stops. But here in PTH is uncontrolled, it keep on having calcium reabsorption. Okay. But somehow Then in these patients, renal function and thyroid function tests are normal. So remember, in case of chronic renal failure, there is secondary hyperparathyroid, and TSH level may be increased little bit in case of lung cancer, right? And ACTH is a feature of small cell lung cancer, and there are no metastasis. The bony pain is also ruled out. So all other options are ruled out one by one. And in fact, your concepts are very clear. Even if you don't go for other option, it's straightforward. The only condition, the golden line, the meaning of golden line is, if it is there, it is virtually diagnostic. It's just like, I asked you one question. Eiffel Tower means Paris. Statue of Liberty means USA. And Taj Mahal means Agra. So they are the virtually diagnostic word. This is the meaning of golden line to remember. Question 10. We are getting 55-year-old man, persistent cough, occasional hemoptysis, 40 years cigarette smoking. Okay, chest X-ray is normal. What are the subsequent chances that lung cancer may be normal? Answer is 10%. What does this mean? It has got a lot of meaning. Patient has, suppose there are 100 confirmed cases of lung cancer. You go for chest X-ray. 10% people may have normal chest X-ray with confirmed lung cancer. It means what? Normal chest X-ray does not rule out lung cancer. That's why we always investigate further if you are strongly thinking in terms of lung cancer. So friends, 10% of the patients who have a normal chest X-ray can have lung cancer on doing further investigation. But still, of course, 90% chances you can detect. That's why chest X-ray is the best initial test. The point to be noted, best initial test is chest X-ray, but normal chest X-ray does not rule out lung cancer. Okay. The patient should be always advised to go for CT scan if you are clinically thinking that I am dealing with cancer. So let us see how to investigate a case of lung cancer. In more detail, your concept will be very clear. Chest X-ray is the best initial test. Point I told you, and I also first investigation, and I told you 10% of the patient may have normal X-ray. The point I already mentioned to you. CT is the investigation of choice. If they ask you first investigation, chest X-ray, but they ask you investigation of choice, then the answer becomes CT scan. Then it's not the chest X-ray. Bronchoscopy has a distinct advantage. It gives you histological diagnosis also. And you can add its efficacy if you add with endobronchial ultrasound. The bronchoscopy is, but the drawback is it is an invasive procedure. But the advantage is you can get it, not only you will come to know that it's a lung cancer, you'll also come to know what type of lung cancer. CT scan can only tell you cancer, but it cannot tell you type. Even you have done CT scan, then most of the time bronchoscopy is needed for a biopsy purpose. PET scan is usually done in non-small cell lung cancer to establish curative treatment. Okay, so we always use this 18FD, which is taken by the neoplastic tissues. The PET scan we do by 18-fluorodeoxygenase, which is taken up by the neoplastic tissues. Okay. So this is usually to look for the metastasis, because if the disease has metastasis there, then the curative rate is very less. Okay, so if the disease is localized, then in fact than any cancer, it is localized, that is give us a good reason to go for surgical treatment. Why he is saying non-small cell cancer? Why not small cell lung cancer? Why? Because in the very beginning I told you, in small cell lung cancer, the disease is, by the time you diagnose, it has already gone. 99.9% has already gone to distant places. So there is no point in going for PET scan. Raised platelet may be seen in a case of lung cancer. So they are all what investigation we have to do. Question 11. 62-year female, 40-pack year of smoking, chronic cough, bronchoscopy revealed a tumor confirmed, biopsy taken small cell lung cancer. Now you could understand this question better because you know the basic concept how to approach a case of lung cancer. There is no evidence of nodal spread or metastasis. Oh, something unique. Come on. Come on, what he says, he got small cell lung cancer, but there is no evidence of nodal spread or metastasis. So TNM is T1 NOMO. Well, what to do? Let's go back to the previous question. So what I told you, I was talking to you regarding PET scan, I told you we do for non-small cell. I also told you that in case of small cell lung cancer, there is no point in doing metastasis. By the time you diagnose the disease, already metastasis. That's why small cell we always treat by chemotherapy and the radiotherapy. There is no role of surgery at all because disease is not localized. But here it is localized disease, it has not gone. So this is surgical resection, and I'm sure most of you have gone for this answer. Yes. You are not wrong, but if you have read the question very carefully, and it's a new thing that yes, what the NICE guidelines say. So now let me tell you what NICE guidelines say. Surgery still plays the little role in the management of most patients of small cell lung cancer. Little role. But as the NICE guidelines say that if the tumor is localized, like in our case, then surgery should be done in early cases. This is as per NICE guidelines. So in this, the disease is totally localized, no metastasis, and this is not a common presentation, it's a very rare presentation. Go for surgery in this case. So let me talk more about small cell lung cancer. They are usually central and they arise from APUD cell. Now you're definitely going to ask me, what do you mean by APUD? A for amine, precursor uptake decarboxylase. So they have a very high amine content, high uptake of amine precursor, high content of enzyme decarboxylase. That's the meaning of APUD. Associated with ectopic ADH causes hyponatremia, Cushing syndrome, and ACTH secretion can lead to bilateral adrenal hyperplasia, and that lead to high amount of cortisol, and that's why it lead to profound hypokalemic alkalosis. Profound, it lead to profound hypokalemia. Okay. Lambert-Eaton syndrome occurs only in small cell lung cancer. It doesn't happen. And why this happen? Let me talk a little bit more about Lambert-Eaton. Antibodies to voltage gated calcium channel causing myasthenia-like syndrome. So as the golden line has been told to you that if you are getting Lambert-Eaton syndrome, you are dealing with small cell lung cancer. It is due to voltage gated calcium channel antibodies. Management, usually metastasis, go for chemotherapy and radiotherapy, but rarely as per NICE guideline localized disease, then we can go for surgery also. And the more extensive disease, then we just have to go by palliative therapy only. Question number 12, 65-year-old, 6 weeks of worsening, shortness of breath, lethargy, COPD is there, she's an ex-smoker, hyperinflated lung field, normal heart size, MCV is normal, other things are quite normal. Most is referral for chest, clinic referral should be done. What is this question? Let's go back to question again. We are getting a 65-year lady, breathless, history of COPD, smoker. Okay. Normal chest X-ray, ex-smoker. She has weight loss, hyponatremia also. There is hyponatremia also. Yeah. 131. And MCV is normal. Hyponatremia is there in a patient smoker. Well, you should investigate. For lung cancer, we have a reason. Now, what is the NICE guidelines? MCV is normal. So that rules out any GIT cancer. In GIT cancer, they have a prolonged bleeding and they usually lead to reduced MCV because of chronic blood loss is there. But in our case, MCV is normal. Now, we have a reason, we have a hyponatremia, normal MCV, ex-smoker, lot of cough. We should refer the case for the lung cancer evaluation as per NICE guidelines. So the NICE guideline for the referral is as follows. Refer people using suspected lung cancer pathway. That means appointment within 2 weeks. Point to be noted. Within 2 weeks, appointment should be, the patient should get appointment within 2 weeks. This is so-called lung cancer pathway referral. For whom? If the chest X-ray suggests lung cancer is there. And we learned that in 90% cases, chest X-ray may show some abnormal, but 10% cases, it may be normal also. Normal also. Chest X-ray may be normal. Or we are getting a 40-year-old male patient with unexplained hemoptysis. We don't know why hemoptysis is occurring. You think about cancer. So in such cases, urgent chest X-ray to be done within 2 weeks. Okay. Again, to assess for lung cancer. So now comes certain more guidelines. This need to be read 2 or 3 times. They're all guidelines. Some you can say administrative protocols are there. So, you may have noted down, or I'll give you time to take a screenshot, or you can write, or you can read later. Okay, fine. Yeah. So go for chest X-ray immediately. To assess for lung cancer in people, who are the people? Age 40 or over, and if they have 2 or more of the following unexplained symptom. Okay. Or if they have ever smoked and 1 or more of the following unexplained symptom. right? So what are the unexplained symptoms? Cough, fatigue, dyspnea, so-called shortness of the breath, pain chest, weight loss, appetite loss. If you just coolly think, what are these? They are all the features that we see in any cancer, especially in lung cancer, cough, fatigue, pain chest, etc. All are the common symptoms that we can see in any case of lung cancer. But they may occur in other conditions also. But they are definitely in a setting of smoker. Then with hemoptysis, you have to think, you have to investigate. Now consider urgent chest X-ray. Again within 2 weeks. Urgent means 2 weeks. Assess for lung cancer in the patient above age 40 years or over with any of the following: persistent or recurrent chest infection, finger clubbing, lymphadenopathy, supraclavicular or cervical, chest sign consistent with lung cancer and thrombocytosis. Point to be noted, they are all well established feature in a case of lung cancer. So again, we have a reason to go refer the patient for lung cancer. The point to be noted: recurrent chest infection, finger clubbing, lymphadenopathy, chest sign, and thrombocytosis. Which one of the following is a contraindication to surgical resection in the lung cancer? We know very well surgery is mainly used for squamous cell lung cancer. That point I told you. So what are the indication? Okay, in this case, vocal cord paralysis is a contraindication of surgery. So paralysis of vocal cord implies that extracapsular spread to the mediastinal node and is indication of non-operability, because this cancer has gone out of the capsule, it has gone to the mediastinum, and now it is non-operable. So let me tell you how to manage a case of non-small cell cancer. We learned that in case of small cell, chemo and radio. Now let's talk about how to manage a case of non-small cells, particularly squamous cell. Okay, only 20% are for surgery. Although surgery is the treatment of choice, by the time you diagnose, patient may not be fit for the surgery. And one more thing, do mediastinoscopy, mandatory, because even CT scan may miss some of the mediastinal lymph node. The additional thing that you are getting is that you must do mediastinoscopy. CT scan may miss something. In such cases, then you go for curative or palliative therapy, right? So we do surgery, but what are the contraindications when you will not do surgery at all? Okay. So if stage 2, 3B or 4 is there, FEV1 less than 1.5 liter, malignant pleural effusion, tumor near the hilum, vocal cord paralysis and superior vena cava obstruction. These are the contraindications. Stage 3, stage 4. FEV1 less than 1.5 liters, malignant pleural effusion, tumor near the hilum, vocal cord paralysis and superior vena cava obstruction. How will you know, clinically, how will you know that patient has superior vena cava obstruction? If you are getting non-pulsatile JVP. Non-pulsatile JVP is an indication that you are dealing with superior vena cava obstruction. One more thing, I just mentioned about FeV1 less than 1.5 liter, but they say, nice guidelines say, that FeV1 even less than 1.5 for lobectomy or less than 2 for pneumonectomy. Some advocate that even at a lesser place also we can do it, but it is just a additional thing. Nobody going to ask you. So as far as our exam is concerned, FeV1 less than 1.5 liter. So don't forget these 6 options which are absolute contraindication to surgical treatment. 55-year-old man, non-small cell cancer, contraindication to surgery is what? FeV1 less than 1.5. Again, you can answer this question very comfortably. Let's look into other option. Body mass is not a feature of contraindication. Continuation of smoking is not a contraindication. Hypercalcemia and T2N1, no, they are not the they are not. But definitely FeV1 less than 1.5 liter is confirmed, and others we ruled out. So contraindication lung cancer therapy is FeV less than 1.5 liter.